Chris will address the topic of newly diagnosed AML.
Morning. Actually my talk will overlap some with yours, so that will allow me to be a little bit philosophic. Because remember, I'm not a laboratory scientist. You want are these slides there? Oh, why can't I see them here? Then I decided to do this. So I think we're living a interesting time in which the genetics are going mid-21st century. Our treatments are mid-20th century. Right? I would be curious just to see a show of hands. Who treats AML with 3+7 as induction therapy most often? What is your most common treatment for AML? Nobody uses 3+7, Ara-C, and some mithracycline? I'm surprised. So I guess not. But, or most people are sleeping, I guess. But, so there is clearly a separation between what we're doing and what we're thinking we're doing. Of course, there's lots of hope, as we see from your talk, that some of the underlying mechanisms that we are seeing, they may help us find new insights that will lead to better treatments. However, you and I know that when it comes to daily practice, that has not fully been accomplished yet. Oh, you're not connected there, are you? So anyway, so I think with this audience, we don't have to discuss this. However, I just want to remind you that an occasional patient with CNS disease at presentation, obviously that has prognostic implications right there. When we start evaluating these patients, there are 2 or 3 informations that are obviously also very strong information, regardless of your molecular or cytogenetic profile of your disease, which is age. Right? We all know that the outcomes of treatment after you pass age 60, 55, 60, it's completely different, period, regardless of the rest. Also, the presence of a history of exposure to chemotherapy, radiation, and a previous history of myelodysplasia. This immediately gives you a different prognosis, regardless of the rest. So if I pass here, it's not going to pass there. So it doesn't matter. So don't worry. Thank you. No, thank you. I thought it would. So it's disconnect. Now, once you do your initial evaluation, also, especially for you folks here, I don't have to mention the prevalence of hepatitis, which is somewhat less for us over there, but HIV is always a problem, and you probably want to start seeing this as early as you can, so you can start thinking, likes of me, about bone marrow transplant. So you want to know that information, obviously, as early as possible. And then what you do? Then you extract DNA. That's great. So what tests do you do? Well, we know what the tests you do, which is this very elegant platform. But is that accessible to us all? And it is accessible in real time for you to make treatment decisions. And number 3, are those treatment decisions available to you, right? Because obviously it's very elegant to know that that is very prevalent and has implications in terms of prognostication, but not necessarily today in terms of treatment. And that's where it becomes a little bit different. Now, preserve blast cells, yes, that's a good habit. Very often I'm asked, why do you do that? Very often we don't know why, right? So you want to have tissue for banking. This is an important habit. And HLA type. With one caveat, always remember that occasionally if you get too many malignant cells, you may have issues. Is it connected now? Oh, thank you. And you may have issues with a depletion of some haplotype in those cells. So if your HLA looks funny, I don't think it's passing yet from here, is it? Aha, it is. So we don't have to talk about FAB, which is slowly but surely going away. We always have to remember, however, you want to know if it is APL. And this is needless to tell you that as soon as you can, so a differentiation therapy can start. And it's possible also that if you see M6 and M7 FAB, you want to start thinking transplant sooner than you would otherwise if that's a transplant candidate patient. Now, so let's say you have cytogenetics in time to make treatment decision. Does cytogenetics impact your treatment decision up front. So if you talk to Dr. Jabbour or Dr. Kornblau here, they give high-dose Ara-C to everybody in the induction. So truly, knowing if it is a core-binding factor leukemia, you're probably going to use that information for your consolidations if you're doing 3+7. But if you're doing high-dose Ara-C up front, it's not going to make that much of a difference. Now, you probably want to know as soon as possible the small minority of patients who have 922 or will be Philadelphia for reasons that you can target that. So that's good. Now, well, hold on a second. What happened here to this slide? Does it show? No, it doesn't. So you saw from the previous speaker, somehow my picture disappeared here, that there's a lot of heterogeneity in chromosome normal AML, which would be grossly 40% of your patients, say. And that the two most common abnormalities, as you heard as well, will be FLT3 mutations and an NPM1, each one pushing the prognostication one way, different way. Now, FLT3, it is possible that adding FLT3 to induction therapy, FLT3 inhibitors, will change, although it's still not totally proven. So that's information that probably will be good to have sooner than later, because you will have a tyrosine kinase inhibitor for that. So that's good. Now I want to talk a little bit about these mutations that we are seeing. So I think it's important to remember that some of these mutations will drive the situation, and a lot of the other mutations will be due to genetic instability. They are not necessarily primarily the drivers of what's happening with AML. But despite of the very important role of the mutations, there are several things that we're not capturing there. Epigenomic changes. So there are several epigenomic changes that are not clearly related to molecular changes in the genome. There are changes in the non-coded parts of the genome, and there are microenvironmental changes that we're not taking into consideration on that. Now, in this prognostication, we also have to remember microRNAs, which are obviously a very strong prognosticator. They do inhibit translation of messenger RNA, and it's unclear to me how to put that in the panels that we have today, especially if you're only looking for mutations. Now, here, it complicates my work, huh? Aha. Now I can't remember what this picture is, so let's skip this one. Since they disappeared, now you're asking my memory after 13 hours traveling, too much. So let's just think here a little bit about, again, the somatic mutations that we're talking about. So you can try to, for educational purpose, to think of them by pathways. So the cohesin complex, for example, will be adhesion molecules and a variety of mutations that are related to that. You have epigenetic related changes, like as in histone or in DNA methylation. And a very interesting group of somatic mutations is this RNA spliceosome, which you see a lot of in cells with dysplasia, right? Like MDS, CMML, and therapeutic-related AML. And as was mentioned before, TET2 mutations are coming very strong. I believe here, Patel basically talks about the prevalence of those mutations, and again indicating that FLT3, NPM1, and CEBP mutations are the most commonly seen. Now, I just want to remind you that this is also complicated, right? If it's not complicated yet, it is complicated. So CEBP, remember, if it's just one allele mutated, it doesn't seem to matter. You need to be two. IDH, depending on the sample size on the population tested, there have been conflicting results in terms of prognostication. And you see here, to add to the complexity, several abstracts from Taiwan that are showing a lot how you can elaborate on this complexity here. So now, let's see what happened here. Okay. To make things more complicated, it may be that the prognostication of some of these mutations changes with your treatment. Here's a good example. Small population. However, for those with intensified anthracycline therapy, you see the prognosticators here. And they may be different if you're treating differently ways, your therapy. This is an analogy, for example, in ALL, with some more intensified treatments, the effect of high white cell count may be much different. So then when you use lighter regimens in induction. So you've seen this statistically change depending on the treatment. Hey, well, let's ignore that one because you already mentioned that. Oh my, I think I'm stuck. So I think it's, wow, I don't know what happened to my, basically all my pictures disappeared. Not really. So you also showed this to some extent in your presentation, which is there are attempts in putting these things together. You just got to remember, and this is the European Acute Leukemia Net. I can't say anything bad about them because Dr. Moti is watching me there like a hawk. So if I'm not going to say anything bad. It's actually a very interesting endeavor trying to put this together with cytogenetics in terms of prognostication. Oh my goodness. So I lost my whole talk, man. Now I have to try to remember what it was here. No, I lost the whole thing.
You have all the figures on your computer? We run it directly from your computer?
Well, it's probably going to delay us so much. What I would do is I'll circulate my slides later. They're mostly educational slides, so that's okay. What this reference is a most recent acute leukemia net from Europe, a signature using now I believe 24 different genes in addition to FLT3, CBPA, and NPM1. And what they show is that they can refine with this extra signature the classification that they had before. What this tells me is that until we have a reasonably agreed upon panel of genes that we are to use, these things will change a lot. And so we got to be careful because obviously, so do I incorporate every genetic mutation that comes in the New England Journal every 6 months to my panel? Probably not, because you're going to have to define some sort of a more rational approach to this. But so I think it's reasonable at this point for sure to have an NPM1, FLT3, and CBPA in your practice. However, and this slide to me was great because basically it adds 24 genes that are different from the genes that you're finding. So it is, you got to be very careful to separate the effect of research on this and your practice on these things. Now, just to make things more complicated, just out of curiosity, who does day 14 marrow after induction? A few people do, right? And what do you do with that information? Right? So 40 years later, we cannot agree even with if we should, and what do we do with day 14 marrows that are equivocal? Say you have flow cytometry positive blasts, so do you give chemo again? And what chemo do you do? So that, again, my discrepancy between 21st century genetics and 20th century treatment, right? But there is definitively dynamic prognostication. It's not up front, but obviously you want to see flow cytometry and molecular markers at remission. That may help you prognosticate and take these people to transplant. Folks who do not recover platelets are not doing well. Those who take forever to achieve remission are not doing well neither. So this is a table that would summarize the current recommendations made by a group of experts. When I reviewed this paper, Dr. Moti, for them, I liked it. And, but my point is, it is an expert opinion. So it helps to make you think two things. One, if you're thinking about bone marrow transplant, what is the treatment-related mortality that for the transplant you're planning, right? That's very important because depending on how high the mortality is, and the risk of the disease, you may not want to go to transplant. So this table here that you see, pretend, helps a lot on that, and I'll give you the slides later. So in conclusion, so I think we are certainly capable today to prognosticate much better than we're able to treat. There's a huge discrepancy these days. Of course, we hope that all these mutations and all these inner works of leukemia that we're learning now will help us treat later better, which should happen. But there is no question in my mind that we are not even close to the hope that everybody has that we could avoid more and more bone marrow transplants for AML, which unfortunately we're not close to that. So obviously the picture is gone. These are my friends. This is Dr. Jabbour, who helps me a lot with slides. He's my, I think there was a picture here, but gone. Well, sorry about that. Thank you.